Good morning, good afternoon, and good evening, depending on where you are joining from around the world. Welcome, everyone, and thank you for joining our webinar, Midwives in Changing Climate, centering SRHR in climate and humanitarian action. My name is Devyani. I will be the moderator for you today. I work in India with adolescents and youths on SRHR. This session is co-hosted by the International Confederation of Midwives, the ICFP Environmental and Climate Change Subcommittee, and the FP20. As climate change and disaster increasingly threatens health and rights, midwives are not only providing life-saving care, but also advancing family planning, community resilience, and sustainability. We are excited to hear from our distinguished panelists who are bringing perspectives from research, humanitarian action, conservation, and global advocacy. Before we begin, a few quick notes. We have language interpretation that is available for today's session. You can select your preferred language by clicking interpretation button at the bottom of your Zoom screen, choosing your channel. Hope everybody have got that button. Few housekeeping notes. This webinar is being recorded. Please share your question and answers in the chat, in the question and answer box. We will address them in the final part of our session. Feel free to share highlights on social media so that we can amplify your voices. To begin, it is my pleasure to invite Neha Mankani, who is Humanitarian Engagement and Climate Advisor at the International Confederation of Midwives and the founder of Mama Baby Fund, to deliver opening keynote. Neha, the stage is yours.
Thank you so much, Devyani. Good morning, good afternoon, and evening, friends and colleagues. I'm really excited to open this really important conversation today. So as Devyani introduced, I'm a midwife from Pakistan and I'm ICM's Humanitarian Engagement and Climate Advisor. And myself and Devyani also serve as co-chairs in the ECC, the Environment and Climate Change Subcommittee for ICFP. And in all of these roles, we've seen how deeply climate change is now reshaping our world and our health systems, and also with it, the realities of all the women, families, and the midwives who serve them. So, well, the International Confederation of Midwives, if you want to know more about it, is the global voice for midwives, and we represent 136 midwives associations from 117 countries. And our associations together, they form a very powerful network. And we speak to them, and what they're telling us time and again is that climate change is no longer a future concern, something we see maybe in like 30 years. It is an everyday emergency. So just to give you a little bit of context, last year, ICM with Human Rights Watch conducted a study, and I will share it in the chat. It's called Interlocked Midwives in the Climate Crisis. And we gathered perspectives from midwives in 41 countries. And the findings of this study were really sobering. From the respondents, 75% said that climate change is already harming the communities that they serve. They're seeing food insecurity, they're seeing displacement, they're seeing disrupted maternal care. Over 70% of the respondents said that their own work has been directly impacted, from health facilities damaged in disasters to supplies cut off by floods and storms. And midwives also reported seeing rising heat-related complications in pregnancy and increased stress and burnout as they try to meet needs in really fragile conditions. So we have associations, as I mentioned, all over the world. We speak to midwives in Bangladesh. They talk to us about how rising floods cut communities off from clinics for weeks at a time. Earlier this year, we did some climate work in Kenya, and our associations over there talked to us about drought and how it's driving food insecurity and really worsening maternal health outcomes. And we have associations in the Pacific Islands who we will often hear from about how storms are destroying their facilities and disrupting supply chains for contraceptives. So every region that we work in, our associations are grappling with the same reality, that climate change is really directly undermining women's access to sexual and reproductive health and rights. So ICM is doing a number of things around climate and midwives, but broadly, the three things that we're doing is we're supporting our associations to strengthen their capacity to respond to climate-affected and humanitarian settings. We are advocating globally so that midwives and SRHR are recognized as essential to climate and disaster policies. And we're trying to build evidence and partnerships to make that link between SRHR and midwifery care more explicit and how it connects to climate resilience and sustainability. So our associations, they consist of midwives, but they're not just service providers. So they do lots of really interesting things in humanitarian settings. They've been really innovative. We see them run mobile clinics after cyclones. They advocate for reproductive rights in fragile states, and they're finding new ways to provide family planning and SRHR services when systems around them are completely collapsing. So the ICFP Environment and Climate Change Subcommittee, which we mentioned earlier, is our partner in this webinar, and it plays a critical role in this effort as well. So together, we're working to ensure that family planning and SRHR are integrated into climate action and humanitarian planning. And whenever we talk about, what we want is that when we talk about SRHR, we should always talk about resilience and sustainability with it. So just to give you a little bit more context about my work, so this work is also very deeply personal to me. So I work in a coastal fishing community off of the coast of Karachi, and I worked alongside midwives and families who are on the front lines of climate change every single day. Rising sea levels, coastal erosion, intensifying heat waves are really threatening their livelihoods and their health. And for pregnant women, the challenges are really profound. So reaching care requires a long boat ride to the mainland, which is really impossible during storms. And midwives in these communities are often the only consistent providers of maternal and reproductive health care. And they work with really limited resources, but they have a lot of potential for transformation of the maternal health and SRHR landscape. And with it, when we talk to midwives in communities, and we often see that they have essential clinical skills, but they also have this trust and they have local knowledge and a commitment to their own community, to the women and families in their own community. So they also, that makes them uniquely positioned to make this connection between health, rights, and resilience. So as we will begin today's discussion, I'm sure we will learn through the really rich work and experience of our speakers that investing in midwives is a big part of investing in climate resilience, and providing midwife support means that we are protecting women's rights and ensuring access to family planning, to SRHR, and to more sustainable communities. So thank you for being here today and for recognizing that midwives must be central to the conversation on climate and humanitarian action. And I really look forward to hearing from our distinguished panel. Thank you.
Thank you, Neha, for setting the stage so powerfully. We will now move to our panel discussion, hearing directly from our leaders who have joined us today. Our first panelist is Kate Charleston, a midwife and nurse with Médecins Sans Frontières. I hope I have pronounced it correctly. Kate has worked in acute emergency settings across Afghanistan, Pakistan, Sudan, Myanmar, Ethiopia, and Ukraine. She brings invaluable insights from the front lines of humanitarian crisis, where ensuring SRHR can be both critical and extremely challenging. Kate, you have worked in some of the toughest humanitarian contexts globally. What barriers do midwives face in delivering SRHR and family planning during crises? And what needs to change to ensure these services are not deprioritized when emergencies driven by climate or conflict?
Thanks, Devyani. Look, I think this is a really broad question, and I think we're probably all quite aware of the day-to-day barriers that midwives are facing. I think there's, a lack of support within the systems that they work. I would say that even within other healthcare professionals, we have a lack of understanding of the scope of what a midwife's role is. Midwives are not just delivering antenatal, birthing, and postnatal care in these settings. It feels like we have constant supply issues, the stigma and discrimination midwives are facing for the care that they provide. And more recently, there's such a huge lack of funding for sexual and reproductive health programs. But I really feel, and, talking to some of my colleagues within my organisation, these barriers will not change without significant change in how the health sector and organisation in general viewing women and girls and their rights. So I've been working with MSF, which is also known as Doctors Without Borders, over the past 5 years. And I think regardless of whether I found myself in an acute emergency setting, and some of those are climate related, or whether we're working in contexts where there are chronic health needs, the SRH needs of women and girls exist everywhere. And these needs always seem to be largely unmet and really deprioritised. I think, though, to answer this question is we need to zoom out for the bigger picture, and the reality is that we're living and working in systems and societies where there are gender inequities, and it feels like the disparity that women and girls are experiencing is increasing. If I think about my experience, I've worked in places where it's restrictive cultural and traditional practices to places where laws are in place, and the laws themselves are affecting the availability and accessibility of services. And it feels like this is only worsening. If we think about the past few years in some of the places I've worked, girls are now banned from going to school in Afghanistan. Roe versus Wade in the US was overturned. And most recently in my last few assignments, I'm seeing massive impacts on family planning and contraceptive care for women and girls related to the funding cuts that we're seeing. And I think if we couple that with what Neha said, a more fragile world and climate change that is happening now and not in the future, the rights of these women and girls to have healthcare is taking a backward step. I think that we're really hearing loud and clear a message from individuals, from governments and societies that the lives, the rights and the bodily autonomy of women and girls is not a priority. And, that translates all the way down to the point of patient care and for the barriers that midwives are experiencing. If I think about MSF as an organisation, as you mentioned, we're working in emergency settings. And I think one of the big challenges with sexual and reproductive health care for women and girls is that it's not always obvious right in front of us when we enter a new emergency. We often focus our interventions around the most obvious issues. So in conflict, we're often focusing on secondary health care with emergency trauma care. We respond to epidemics where we're trying to treat and prevent the spread of further disease. But it's not, I feel it's not as clear for myself as a midwife and for other midwives to see the immediate effects on the accessibility of SRH care. And therefore, it's also hard to advocate for that care to be a priority. Something that MSF has done recently is tried to implement a maternal death surveillance tool, specifically designed to implement in the first phase of an acute emergency. And this obviously looks at maternal death, which is an important indicator, but it's still not easy to measure and look at the other effects that women experience. I think we have a long way to go in ensuring this care is provided and that midwives are supported and that some of these barriers are broken down. But I think we also need to be critical of ourselves on how we can improve. And I just wanted to share with you all a very short example. In 2022, I was involved in an emergency intervention in Pakistan, where the country experienced really widespread flooding. The authorities announced that 1/3 of the country was underwater, over 30 million people were affected. It was really quite a massive emergency. And again, we saw such high needs and we had to focus our medical intervention on what seemed obvious, and it was malaria and it was malnutrition. And these are something that's very measurable and something we were seeing at very alarming rates. And at the time, it made sense to focus on those morbidities. But I was also involved in the reflection process of this emergency intervention. And after a 10-month intervention, we hadn't provided sexual and reproductive health care. And to think of how easily we could have integrated that into care, I think it was really remiss of us not to do this. We could have provided all facets of sexual and reproductive care, but really I was thinking very much about family planning, for these displaced women. I share this experience because I think that, to answer your question, the barriers that midwives are facing are not solved at the point of patient care or at the point of the programs and the care delivery. I think that SRH care needs to be prioritised at the highest strategic levels in health systems and organisations and in all contexts and emergencies. I know that within Within MSF, myself and my colleagues were really advocating that sexual and reproductive health care needs to be integrated into all medical programming. And that's particularly so impertinent now in the current landscape where we're seeing standalone SRH programs be defunded and deprioritised at really an alarming rate. So yeah, we keep advocating for that. I think whether we are running a HIV and tuberculosis program or whether we're running a nutrition program for children or responding to an epidemic, these needs still need to be a priority and we need to be delivering that care. And I think it's only going from that higher perspective that we're going to actually better support midwives to overcome the barriers that they're facing.
Thank you so much, Kate, for sharing your experience. Our next panelist is Macarena Martinez, a midwife, assistant professor, and a doctoral student in public health at the University of Chile. Her research focuses on the impact of climate change, particularly extreme heat on maternal and perinatal health. She is also a leader in clinical simulation for obstetric training and a strong advocate for equity and climate justice. Macarena, can you share some key findings about how rising temperature are affecting pregnant people and what this means how we prepare public health system and train midwives in changing climate? Over to you.
Hi, Deviani. Hi, everyone. I'm getting over a cold, so please, if my English is hard to understand, please let me know. As Deviani says, I'm currently an assistant professor and midwife and a student at the Department of Newborns and Women Health at the University of Chile in Santiago, Chile. And my current research looks at the intersection of climate change and maternal health, with a particular focus, as you mentioned, on extreme heat. And many people ask me why heat matters in pregnancy. And just a quick reminder that pregnancy is a period of increased physiological stress. So blood volume rises, the heart works harder, and thermoregulation is already challenged. This makes pregnant people more vulnerable to heat. When temperatures rise, their bodies need to work hard to stay cool, and this can have consequences for both maternal well-being and fetal development. As you may see, the World Health Organization with other organizations made this conceptual framework, which I do believe is most of the self-explanatory one, which also tell us like climate change and extreme climate events are related to heat hazards. So there are critical windows of exposure and it affects women, the planet, and the families. So we can have a direct influence like dehydration, hypertension, preterm labor, and stillbirth, which is the worst outcome. And indirectly, we, as Niha mentioned, we had food insecurity, food housing problems, work conditions, and health system performance is usually reduced. So extreme heat is not only an environmental stressor, it's also a determinant of reproductive justice and health equity. There are several multi-country studies that shows that the risk of preterm birth increased significantly in hotter days. In my own ongoing research in Santiago, Chile, we find that heat waves are associated with the spikes in preterm deliveries, particularly among socially vulnerable groups. Or preliminary results looking at the urban heat island effect, that's what I'm looking at, show a marked difference in exposure according to socioeconomic strata. Women in poorer neighborhoods are significantly more exposed to higher nighttime temperatures, which increase health risk. This is not a new problem, okay? So if we go to the next slide, we can see this going for far beyond 2023, but we usually forget, right? When we don't see this happening all the time, we usually forgot. We are expecting heat only during summer, but we have the worst winter heat wave in the South Cone in August 2025. As you may see, like Chile is this long country, and these red dots follow from Peru to Chile and part of Argentina too. These patterns aren't theoretical, so we can see how climate extremes are stressing health systems. In Chile and Argentina, we have these heat waves, and this heat wave triggered wildfires and spikes in hospital visits. In Brazil, historic floods and droughts disrupted prenatal care and delivery services. That's 2024, the worst one reported yet. And in Mexico in 2023, and in Central America, extreme heat has caused power outage and water shortages, making it harder for pregnant women or people to access safe and continuous care. These events remind us that the climate crisis is already here, shaping maternal and newborn outcomes in real time. What does this mean for practice? First, we need to introduce preparedness in health facilities. Maternity wards need to be adapted for other climates with proper cooling and protocols for heat stress. Then we need to develop clinical guidance. We need to teach people how to treat a heat event in pregnant women. And midwives should be training to recognize and manage heat stress in pregnancy and to counsel women on hydratation, rest, and safe behavior. Third, community engagement. So we need to trust local actors who can help families adapt, whether by creating cool spaces or advocating for green neighborhoods. And finally, we need to do what we're doing now, like policy and advocacy. So ICM is currently working strong in this environmental committee. And I do believe midwife voices must be heard in climate adaptation planning because maternal and newborn needs are often invisible in those debates. As Kate says, also contraception is a big issue during flooding, heat waves, or wildfires. So I want to conclude saying that extreme heat is not a distant future problem. It is already here and is already shaping pregnancy outcomes in our region by integrating climate awareness into maternal health system and midwifery education, which is so important. We can reduce preventable risk, protect maternal and newborn health, and build more resilient community. So thank you so much for listening to me. And please, if you have any question, you can reach me through the chat or maybe email me at my main email. I'm going to put it on the chat.
Thank you so much, Macarena. Thank you so much for your insights. Next, we have Sarah, Uganda manager for the Margaret Pike Trust. Sarah is a nurse midwife with 18 years of experience. 15 of them are dedicated to leading initiatives in reproductive health and environmental conservation. Through her work, she has trained thousands of health workers in family planning and integrated reproductive health with wetland conservation, showing how ecosystem health and human health are deeply connected. Sarah, how do you see midwives contributing to both ecosystem protection and community health? And how does this integrated approach support resilience in both people and the environment? Over to you, Sarah.
Okay, thank you so much. I'm proud to be presenting the Margaret Pike Trust, the UK-based NGO that has been working for the last 50 years to improve access to contraception and to reproductive health care. So the trust came to Uganda 9 years ago, where they expanded the reach, which is where I first became aware of their work. And by that time, I was working as the family planning trainer for Uganda Protestant Medical Bureau and a midwife in charge of sexual and reproductive health department in Bwindi Community Hospital. This one is based in southwestern Uganda. So in the years that followed, used the gained experience of working with remote and rural last mile communities as a family planning trainer. And we developed the Trust Family Planning Training Model, which is the Uganda Sexual Health and Public Education, which I am managing in the region. So in my work as a midwife over the years with rural communities, I have seen many issues linking people's health and the health of their ecosystem. For example, in Ruchiga district in Uganda, where we have been working for the past 5 years, implementing our integrated human health, livelihood, and environmental conservation project. This is funded by the UK's Department for Environment, Food and Rural Affairs. We found that people live in communities reliant on health of the wetlands, and this is where they get their food, this is where they get their water and their livelihoods. So we found that this one puts them at the risk of being degraded. So before we started working in Ruchiga district, we had baseline research where community members told us they had an unmet need for family planning, as due to many barriers, these are such as untrained health workers, stigma, myth and misinformations, and they had long distances going to the health facilities locally in the area. So this made them unable to exercise their reproductive choice. So this resulted into being more poor, and they had families which they were struggling to support. So while working with the London School of Hygiene and Tropical Medicine, we conducted extensive research into the community needs. And there we found there were two clear pathways that were impacting people's reproductive health. One, we found that climate variability and unsustainable farming practices were leading to the degradation of the upland farming soils and wetlands. This was causing more soil erosion and leading to poor crop yields and poor health and nutrition. So we also found that due to lack of quality family planning services, people were having more children than they desired. And this was putting more pressure on the little existing farmland. And this meant that people had insufficient food. And it was increasing poverty, and this was driving rates of domestic violence. And in turn, it was worsening the already poor access to healthcare and family planning. So in order to respond to these community identified issues, we developed an integrated program which helped to strengthen the health care services and public awareness around how people's health and environmental health are linked. So in responding to your question, I can say I have found that midwives are actually perfectly placed to lead these projects as they are embedded deep in the community. We understand the link between nutrition and maternal and child health outcomes. So when a midwife works with partners with different expertise, like farming skills, we can be able to work together to prevent malnutrition through improved farming techniques. And we can also improve food security as well as healthy eating. Midwives need to approach the community education with information about what's happening around us. This is in order to bring about change. This is not only on nutrition, but on health as well. So there are positive impacts in a multitude of development sectors. People's health is better, their livelihoods are more varied, and the practices are more sustainable. And even the village looks better because people are now recycling and they care about their surroundings. So midwives' roles does not only end in the maternity ward. We are able to affect the environment and health-related outcomes in the community. And this can be done through removing barriers to family planning, integrating training in the community, relationships with government officials and other environmental organizations so that women and girls are healthier, we are more empowered, and ultimately the community are more resilient to climate change. So that's how I respond to our question. Thank you so much.
Thank you so much, Sarah. It's very important to talk about. You have talked about it. Next, finally, we have Miret Khalid, a multilingual health system researcher, an SRHR advocate, currently leading Push, a global movement centering women's voices and midwives. Mirat has worked at WHO, White Ribbon Alliance, and PMNCH, spearheading campaigns like What Women Want and Born Too Soon, amplifying millions of voices of women and turning into evidence and policy action. She is also the co-founder of Women in Global Health Egypt and has worked consistently to embed gender transformative approach in health systems. Miret, how does this climate change intersect with the Push campaign's goal? And what kinds of policies or investments are needed to better support midwives in climate affected communities? Over to you.
Thank you so much, Devyani, and thank you for the opportunity to join this very interesting conversation. Thank you, Neha, also for queuing up the slides. So, in order to answer your question, I want to share very briefly about the campaign and its goals. So we already know that rising climate-related disasters disproportionately harm and affect women and girls by disrupting access to SRHR, increasing preterm birth, maternal and newborn mortality risks, heightening the exposure to gender-based violence, and of course, more dire risks of hunger and malnutrition and infections, as shared by my esteemed panelists. We also know that midwives are critical in providing dignifying and women-centered care, which is why, as you see from the slide, Push campaign is all about woman-centered care, advocating for midwives as the way to get us there. Push campaign came as a direct response to what women want. And aims to show the critical partnership between midwives and women. So in a global campaign, the What Women Want campaign, partners all around the world asked women and their communities what they wanted most for their health and well-being. And unsurprisingly, about 1.3 million women who participated in this campaign told us that women want holistic and dignifying care. They want safety from violence. They want access to nutrition and food security. Women want clean water and clean communities. What they're asking for is not rocket science. It's very simple. It's holistic, women-centered care. It's food, it's water, it's being integrated within climate response plans. And what we thought with the Push campaign is where you are seeing women and young people advocating, whether it is for climate justice, whether it is for equal pay, whether it is for gender equality, you will see midwives advocating alongside them in partnership and in solidarity. Which is why, as you'll see from the slide, the campaign is really centering women and advocating for midwives as a key solution. We're doing this through 3 ways. Neha, can you just click one more? You'll see here we're doing this through mainstreaming women-centered care to the public, and we want to see here women-centered care as the standard of practice. We don't want to hear any more stories about women and girls going to providers and saying, you were lucky you had a good provider, that's why you had a good experience. And I see so many people nodding already because so many of us have heard this. We want women-centered care to become the standard practice. And we know that midwives are the provider of women-centered care. So we also are looking to mainstream midwives into policy recommendation. Beyond just ministers of health and the health ministers being the ones talking about midwives, or the maternal health people talking about midwives, we want to see people at COP, people in ministries of labor, in ministries of finance, and of course parliamentarians. Those who are advocating for social change, we want to see them also integrating midwives in their policy recommendations. And of course, that means we need to be building a multi-sectoral, multi-sector campaign and movement. So climate people, this is for you. This is your campaign too. And so with that, I want to invite you to be part of the Push campaign. And to specifically answer your question, can we jump to the next slide, please, Neha? I want to focus on, I want to first of all show you the slide, which is the first step in joining the Push campaign. It's very simple. You agree to 3 things, and through this QR code, you will have access to the Push pledge, and this is how you join the campaign. We know that midwives are on the front lines of climate and humanitarian response. By being embedded in their communities, midwives know the needs of the people that they serve, of the women they serve, and they also know which solutions work best for them. Which is why we are really excited to be at ICFP this year. We're going to be launching an evidence advocacy brief. So colleagues who are going to be at ICFP, I invite you to stay tuned. There will be more information with that, and you will access it by signing the push pledge through forthcoming communications. So I apologize. As an advocate with the push campaign, what can you advocate for with us? We know that midwives are not just responding to climate change and the risks it poses on women and their communities. We know that midwives are also delivering care close to the communities. They're reducing reliance on high carbon transport. They are reducing unnecessary interventions. And because of that, they're also helping us cut health system costs, health system inefficiencies, and inequities. We know that midwives and investing in midwives build climate resilience. It helps us create green jobs for women and address issues of gender inequality and increase economic growth. These are just a few things that you can advocate with us as part of the push campaign. It's so clear midwives are a key in climate action and advocacy. Yet few people see the impacts of midwives beyond catching babies, and that's why we want to invite you to join the movement and help us change the narrative around midwives and advocate with us to put them in every solution. The next slide will show you a QR code where you can join the campaign and add your voice through specific stories, through adding a story of how you have experienced the care of a midwife through women-centered care, or how you've seen a midwife on the front lines. Midwives are superheroes, like Neha, who shared her personal story, and Kate, who shared her personal story as a humanitarian, and Macarena, of course, and Sarah. These are all powerful advocates. Midwives are advocates, and we want to elevate their stories. So, to specifically answer your question now, Devyani, about what specific policy changes we want to see, I leave you with three things. The first is we need to invest and value midwives as experts. Governments and donors must integrate midwives into national climate adaptation plans. We want to see midwives integrated within humanitarian response frameworks and financing mechanisms, recognizing midwives as essential actors in building gender equitable health systems and climate resilient health systems, of course. Number two, we need to be more proactive about closing the gender pay gap. We know that midwives are predominantly women and they are community-rooted leaders. 93% of midwives around the world are women, yet women in the health sector only make up 25% of leadership roles, and shockingly, they make 24% less than their male counterparts. So if we really value midwives as leaders, and we want to really advocate for them to be part of the solution, we need to adequately compensate them. And then my third and final point here is we need to invest in midwife-led solutions. The examples shared by my colleagues on the panel are perfect. And this is what we're talking about. They're simple and very practical investments that we need to be funding. Funding midwife-led emergency trainings, their mobile clinics on the front lines, their digital health innovations for climate-affected areas. We know that investing in midwives strengthens climate resilience and also, most importantly, ensures that women's voices and women's needs shape preparedness, response, and recovery. And most importantly, investing in midwives also helps shift power to those who are most affected. So with that, I want to invite all of you once again to join the push campaign and help us get this message across. Thank you. I'll put the link in the chat. And back to you.
Thank you so much, Merit. And thanks to all our panelists. It was really an eye-opening session for me. We'll now turn to questions from the audience. Please continue to drop them in Q&A box for your speaker or for anyone if you want. So I see three questions here. So I don't see any specific speaker for the first question. So in your experience, I'm just narrating the question. In your experience, how does community trust influence access to SRHR during emergencies? And what policy changes are needed to better support midwives in delivering these services in fragile settings? Any speaker can answer this.
Kate, do you have any thoughts on this? All your experience in the humanitarian settings?
Hi, Neha. I just commented I couldn't actually see it. If you could repeat it, Devyani, because I was trying to read along, but I couldn't see the question.
Sure. So it's, in your experience, how does community trust influence access to SRHR during emergencies? And what policy changes are needed to better support midwives in delivering these services in fragile settings?
I would say community trust is one of the most key components, and I think when I'm talking to my teams, I think we have to start, within however we're providing the care, whether it be in clinics, hospitals, on the move, and I think it starts with confidentiality, right? I think that's the single most important thing that we can do for women and girls, and then that builds that community trust. I think it really varies where you're working, in what context and to what level you're discussing about what care you're providing at a wider community level, and what groups of people you want to target. But absolutely, it's one of the most key things that we always try to make sure that we incorporate in emergencies.
Thank you so much, Kate. The second question is from Tefa Innocent. I think it's for Neha, because it is directed to the ICM. So what is ICM doing to bridge the gap in terms of knowledge, education for midwives, like subsidized education and short course for the midwives, especially in the resource limited setting? And the second question is, what is ICM doing to prevent or reduce rural exodus, especially from Africa, where the impact on women's health is most impacted negatively, to Europe? Neha?
Thank you, Devyani. So thank you for that question. I think, so in terms of knowledge equity for specifically, I'll speak to the work around climate and humanitarian. So we have last year, after we started working on this topic extensively, we have done a lot of content development on it. And we're actually in the process of turning some of this content into open source information that we will in the coming months share with associations and with midwives. So you will be seeing a lot of this work online, and you will be learning. And whenever there is new, big part of what we want to do is also whenever there's new evidence, because we believe that specifically around climate, because we're learning new things every day, whenever there is new evidence that we learn about, we are sharing that through our channels. So you should, if you keep in touch with what ICM is doing, you will see a lot of this work come up in the next few months. And in terms of the rural exodus, I think that is not something that ICM can directly impact, but because we work through associations, and through global advocacy, what we advocate for is that conditions for midwives in country should be such, they should have equal pay, they should be well resourced, they should have good working conditions so that they don't want to leave their work and go to other places where they're treated better. So, or are paid better. So we work through our global advocacy, we're trying to do this, and also through our work with local associations, we're trying to get associations to advocate for this as well. Thank you. I think you're muted, Devyani.
So sorry. Thank you so much, Neha. The other question is to Professor Macarena. What type of epidemiological evidence most strongly supports the association between heat wave exposure and adverse perinatal outcomes, including but not limited to preterm birth?
There are plenty of studies that support that heat and most not only heat waves, but heat is affecting not just preterm birth, but also lower weight. And most of the studies, though, are made like ecological type studies. So because randomized trials are not available, that's the current high level of evidence. So, but there are some studies that cover time stratified case crossover studies on heat waves and deliveries, and probably the most striking for me is like stillbirth is something that we sometimes do not have a specific diagnosis to happening, but heat is related to stillbirth. So that's one of the most the most controversial now. And for sure, like large studies are provided from ES Global, which is Center of Research in Spain. Spain has been affected with high temperatures from, I do believe, 2020 to now. So they have the largest studies in Europe. And probably, I do believe that that's pretty much what I can say from non-epidemiological standing. But currently research, like primary research studies are being going under.
Thank you, Macarena. It was from Rayan Viverosan. Sorry, I did not mention the name. The next question is for, I think, Sarah. So Sarah, this is from Karina, and she's asking that at the Margaret Pike Trust, we have been advocating for the inclusion of SRHR in national climate plans and policies and in funding mechanisms. And Mirat mentioned the importance of this being a topic at COP and other such forums. What work they are doing to really speak to that audience and engage with climate people, providing evidence, etc. Sarah, over to you.
Sorry, I don't think Karina was asking me. Karina is my colleague. We work together.
Okay, I'm so sorry. So you can answer because there is a, she has not, she's asking.
I think Miret can answer because it's about how are we getting things to, how are we getting, what are we doing about becoming part of these larger conversations, maybe?
Thank you so much, Karina, and thank you, colleagues, for that. I was actually just typing your answer in the chat, so good opportunity. I think you're very correct that unfortunately, these spaces, especially these global advocacy spaces, continue to remain quite fragmented. I think those who are existing in those spaces will attest that midwives are not sufficiently integrated within those global health advocacy spaces, and even more so, or even fewer within the climate space. It's very, very seldom that you will see midwives who are also advocating at COP, who are advocating in these high-level climate action fora. So what we're looking to do specifically with the PUSH campaign is bringing together different types of actors from different spaces. So those who are advocating for gender equality, those who are advocating for climate action and climate justice, young people, those who are frontliners and humanitarian health workers, to elevate key advocacy messages that we are developing and synthesizing through the PUSH campaign. We're looking to take the published evidence, like Macarena was mentioning and other colleagues were mentioning, and put it in the language of advocates and put it in the language of policymakers who are present during these different global advocacy meetings, including COP. This report that we are working on, it's actually an evidence advocacy brief that's going to be launched at ICFP. It includes 4 main advocacy arms. The first will be health, of course, and here we're really specifically looking to expand the conversation about the role of midwives, also in SRHR, not just in maternal and child health. So number 1, health. Number 2, gender. Number 3, climate. And number 4, the economic case for midwives. And so this compendium of advocacy messages is what we're looking to equip all of our colleagues within the advocacy space, whether you work in climate or you work in gender or you work in finance, to say midwives are a key solution and this is why. I hope that answers your question and I appreciate it again. Thanks, back to you.
Thanks, Mirit. The other question is, there's no speaker mentioned here, so I will just state it. How can digital and e-learning tools support midwives in strengthening their education and ongoing training around the impacts of climate change, especially in remote settings? And this is from Rajat Anil Kumar. Any speaker?
I can contribute a little bit because I'm just thinking about the tools that we're developing at ICM, and there is just a really big need to do a lot of these digital tools, specifically because a lot of online trainings are not, a lot of people who don't have good internet access or good connectivity are not able to access online trainings. And in the face of sustainability, we also want information to come to people versus people always having to go to information. So there is a lot of now bite-sized learning around where you can learn things from your own home, and I think they have a really big role. And this will be some of the work that we'll be doing at ICM in the coming year, and we'd also try and measure what impact it has on learning for midwives, and then we'll share back. Thank you.
I think we can take one last question. So the other question is from Fabiola Gretzinger. What research gap do you see on the impact of climate change on women's health? As Macarena mentioned, there is a bit of research on the impact of heat. Are there other climate change related issues that you think need to be researched further to understand their impact on women's SRHR?
Can I take that one? So I
Sure.
do believe there is a bit of evidence that's right on heat, but there is a lot of undergoing issues like climate-driven water and food insecurity, displacement, vector-borne disease, service disruption that affect directly women's sexual and reproductive health. So we need to get stronger on, for example, mental health and gender-based violence in context of climate shocks, for example. We have no evidence available to work on that. Maybe I do believe there are also air pollution and wildfires. There is an interesting conversation on the chat right now, are linked to preterm birth, stillbirth, preeclampsia. We have disruptions to health systems that we need to address, and we need to develop more information regarding that. How services strive under these extreme climate effects. Water sanitation, social and structural vulnerabilities. There is a concept called climate migration that probably a lot of people is living. If a lot of countries are under stress due to climate migration, some displacement is occurring, like within the borders of the country. There are people only changing regions, cities, but that moving, it's really something really important, because people shouldn't be displaced because of climate conditions, but they because they have a place, a home, and cultural customs that shouldn't be hindered by climate effects. So pretty much migration and displacement also put a lot of stress in health systems and create this this equity gap, because impacts goes to adolescent, indigenous women with disabilities, and those in low resources or conflicted areas, or areas with environmental problems that were created by this extreme phenomena. So there is a lot of things to do. So please help us.
Thank you so much, Macarena. So we are nearing to end this session. Thank you to all our speakers for your powerful insights, and to all of you who have joined us today. What we have heard today is very clear. Climate change is not only an environmental crisis, it is a reproductive crisis, it is a gender equity crisis, and a humanitarian crisis. And the very center of the response are midwives. From ensuring access to family planning in emergencies, to linking reproductive health with conservation, to advancing research on climate impacts, to leading global campaigns like PUSH, midwives are driving resilience in ways that too often go unrecognized. Today, our call to action is very simple but urgent, and as Miret, I think, mentioned, and I would like to repeat it here, that invest in midwives as leaders in climate and humanitarian response. The second one is integrate SRHR and family planning into climate and disaster strategies. And the third one, and most important one, is the elevate the voices of midwives in global decision-making platforms from FP 2030 to COP negotiations. Because when midwives are supported, women, families, and communities thrive, even in the face of crises. Thank you once again for joining us, and let's continue to push for health, equity, and sustainability. And we hope to see many of you in person or virtually at the ICFP in November.